We're all good?
Everywhere you're good.
Excellent. Welcome, everyone, to Fertility Factor Fiction. I am your host, double board certified reproductive endocrinology and infertility specialist. That was a mouthful. Dr. Rahi Vickery. And I am here with my good friend Tarek Ibrahim from the Ibrahim Strategies Group, who for, I don't know, 5 years was off camera, right?
Doing Dr. T stuff all day.
Yeah, we kept you in the dungeon
I
for
was in
years
dungeon.
until we released you, yeah. But now he's out. So are going to be. There wasn't any great studies to share, although last week we had that amazing study about dual or double trigger, which hopefully everybody is doing. And we've got some exciting videos coming out. Thank you to all of you who have supported us on Instagram. Instagram finally appears to have recognized us since we've had 1.3 million views in just the last 30 days, which is incredible. So the word is getting out, and we appreciate that. Throw up some likes if you're watching on TikTok or Instagram. Our TikTok fans actually have driven many of our videos over 1 million. So we love you guys very much. And yeah, so nothing super exciting in the fertility world recently. Everybody's finding plastics in semen and follicular fluid. Not sure what we can do about that. Tons of information on trying to improve outcomes with AI, but no one's really found a perfect fit for anything yet. So nothing super exciting to talk about there. And very interesting, we just created a video today on Mary Lou McDonald, the leader of the Irish Sinn Féin party, which is the lead opposition party in Ireland, actually went to their equivalent of Congress or government and demanded that they take better care of women with endometriosis, which I thought was just absolutely heroic. As a big endo advocate, I don't think we do nearly enough for those women. And she said enough is enough. The government has to provide better care. I guess there's very poor care for endo in Ireland. Having been there and seen it firsthand, it seems to be true. Patients can't get medication, they can't get diagnosis, they can't get treatment, and they certainly couldn't get surgery. Last time I was there, I was being told that there was virtually no one in Ireland that did endometriosis surgery, which is just crazy. So I think that this is a huge leap forward for them. And I really applaud her efforts to stand with her sisters and say, enough is enough. It's time to do something about this. So huge round of applause, lots of likes and love. So way to go, Mary Lou McDonald. And I'm sure by tomorrow, other government people will be thinking this is a good idea and we should latch on to this. So hopefully, both inside and outside of Ireland, endo is going to start becoming something people notice.
Well, the hope, of course, is that the government actually does something about it. So
Well,
she raises the banner. She's calling it all out. And she had a beautiful quote that you touched on. So I don't want to steal that from your thunder. That was a nice quote she said. But okay, do something,
yeah, for sure. And I think hopefully, I mean, she really kind of socked it to people with hard numbers and talking about the thousands and thousands of women that suffer and the impact it has on so many different things. And she was quite kind of graphic and gory about how it can impact your organ function. So hopefully they'll do something about it. But what a model for other politicians to follow in the rest of the world. Like we just don't do enough about it. So this would be amazing. It's horribly underfunded. Yeah. Research in endo is horribly underfunded. Treatment is underfunded. And really the lack of knowledge is kind of astounding. One of the reasons we've grown so much is because we pay attention to endo, we pay attention to adenomyosis, but a lot of people don't, or they'll tell you that it doesn't matter, and it does matter. It makes a huge difference in your outcomes. So, endo matters. Hashtag endo matters.
One of the viewers on here said, yes, she did. I'm Irish. Yep, all true. We did this chat.
That's awesome. Yeah, that's amazing. So I'm glad to see you guys are finally getting the help you deserve. It's midnight or 1 a.m. in Ireland. So thank you for staying up to watch. That's amazing. So yeah, today we just are going to answer questions. Like I said, nothing super exciting in the fertility world. And exciting at VRC, we will have our own PGT program in the near future. And then from that, possibly some other stuff. We hired a great guy who is now working with us, and he's very keen to expand into other things. So yeah, we may have our own program for a whole bunch of different stuff. So I'm excited about that too.
First question of the day.
Ready to go.
Ready to go. You ready?
Yeah. The goal one of these days is to actually finish the questions.
Well, this is a lofty goal.
Yeah. Once upon a time, we actually.
Oh, we I think
once or twice. Yeah, once or twice we actually finished all the questions, but that hasn't happened.
No. Now we're in a major deficit these days. We're just trying to get through. We're just trying to survive.
Yeah. All right.
Hi, docs. How do you prioritize patients for government-funded IVF? If I choose to pay out of pocket while waiting, will I lose my place on the waiting list?
Yeah, great question. So we prioritize at our clinic by splitting women into over 39 and under 39, and allocate the funding half to those two groups. Within that, it's just first comes, first serve, because we tried it another way and it was an epic disaster and very difficult to manage. So that's what we've been doing with our funding so far. The only exception to that is that if the patient has cancer, we do take that very seriously, and they are given a cancer cycle, even if it means bumping somebody else out of line. With regards to paying privately, no, you do not bump yourself out of the line or switch your place in line. Nothing changes with that if you pay a private cycle. Also, if you're here in Ontario, very important for you to know that the government has actually made it way more affordable, especially if the price of the IVF cycle is affordable. So let's take our price, $12,745, and that includes your first embryo transfer, frozen embryo transfer, and you get $5,000 tax credit. So now it's actually $7,745, and then you get some of that money back in your taxes as well, usually around 20 or 30%, although everybody's different. So it can be as low as about $5,000 to do your IVF cycle. Does not include meds, does not include genetic testing or additional treatments, but like it's getting way more affordable. Having said that, I was at my Sarnia clinic yesterday where a patient burst into tears when she asked me how much we cost, because the other clinic she had spent 2 years at, she didn't do IVF because they wanted to charge her $30,000 for the IVF cycle. And that did not include a frozen embryo transfer. And so she was mortified that we were so much cheaper. And she said, "Why are you so much cheaper?" And I said, "Well, we just don't gouge people. And I'm not owned by venture capital or private equity or some giant group. I'm owned by me." So we just keep our prices very reasonable for people because we want to help you out. So it can be very affordable these days to do IVF. I'm not saying it's cheap. $5,000 to $6,000 plus meds is a lot of money, but it's manageable for many people. And if you're having trouble, let us know. We have financing options. We can do our best to help you. There's the Fertility Friends Foundation you can apply through. So there's all sorts of resources available to try and get through this.
Hello, Dr. V.
They left you out. I'm sorry, man.
And IT Dr. T.
Oh, IT Dr. T.
I got a whole title there. With a heart afterwards.
Very nice. Yeah.
My clinic wanted me to stop estrase and prog at 10 weeks. Was very skeptical. I continued 11 and tapered it off. Tapered it off by 12.
Yeah.
Still on prog. I am prometrium. How long do you have your patients on until? Also, my OB said that I should increase from 1 to 2 baby aspirins during the second trimester.
Oh, interesting. So there's actually nothing wrong with tapering off your progesterone and estrogen at 10 weeks. There's no evidence for continuing it. So you can definitely start at around 10 or even 11 weeks. But if you want to go, we go till 12. At 12 weeks, we definitely stop the PIO. There's no reason for you to continue doing progesterone and oil. You're just going to have a very sore bottom. And at the that point, we reduce the vaginal progesterone dose by half. So if you were doing 2 prometrium 3 times a day, we switch to 1 3 times a day. For our patients, we continue them till 36 weeks because IVF is associated with a higher risk of preterm labor. With regards to aspirin, I am not aware of any direct evidence that says some women should use 81 versus 162 unless they're older. For older women, there is some evidence for that. So I don't know your age, but that's the only time where we do that. And it's not an increase in the second trimester. You're supposed to start with that ahead of time. Increasing aspirin after the start of the pregnancy doesn't actually help you in any way whatsoever.
Hey.
So
most likely getting DE.
Okay.
Was told I've got meds to go into full menopause before, as I've adenomyosis. Is this correct?
Not sure what part of that they're asking about. So if you're going into menopause, it's very reasonable for you to be getting donor eggs. So that makes sense. It may not be your only option, but it's a very sensible and logical option. If you're asking if you need hormone replacement because you're going into menopause, yes. And you can't avoid that if you're going into menopause because we do need estrogen in order for your body to produce a lining to accept an embryo. If you're not naturally producing estrogen, we have to give it to you. Do I like that? No, I'd much rather let your body produce its natural estrogen and keep that estrogen level low, which is why we use letrozole. But if you're not going to respond to the letrozole because you're becoming menopausal, you don't have any other choice other than to do a hormone or medicated cycle. So I get what they're doing, and I would support that in that instance.
Hello, amazing doctors. No questions.
Oh, very nice.
Just thankful for all the effort.
Oh, that's sweet. You know, we get a lot of you thanking us online for all the work we do into this and, you know, for helping the community out. And I really appreciate those comments. They're wonderful comments. It's heartwarming to know that we're making a difference for people and that, you know, people are watching and listening and learning from this. I love that about this show. And, we both do. I mean, I can speak on behalf of both of us.
I'm constantly learning.
Yeah. And we love the fact that we make a difference for people. Like, it's a labor of love. We put a lot of hours into this. We spend, so you guys don't know this, but we spend anywhere from 3 to 4 hours every Tuesday doing this because we're making videos ahead of time. We're strategizing. We're talking about how to grow it, how to make it better all the time. Now we've got our podcast series coming as well. So we spend a lot of time doing this. We don't, you know, make money from this show in any way whatsoever. So we love it because it helps us. Actually, that's not entirely true. We do make about $150 or so a month from YouTube, which I think we put back into advertising because I've never seen a penny of that money. So yeah, maybe someday we'll have a big pile of money that we didn't know about.
I'd love to see that big pile.
not anytime soon, that's for sure.
Hi, doctors.
Hey.
Getting bad migraines from Lupron letrozole. What can I take or do, and what should I ask my doctor for? And that's from Tik Tok.
So there's not a great option there. You could try a beta blocker if your blood pressure is stable. You could try migraine medication, Tylenol, go for massage, physio, acupuncture. Just avoid the estrogen that your body wants. If you do need something, take a progestin. Don't take estrogen, but ideally you avoid it.
Since starting DHEA for upcoming IVF, my wife's cycles have been all over the map. But she and testosterone levels are normal. The nurse says to keep taking it. Is there anything else to test?
I mean, I would retest all your hormones, FSH, LH, DHEA, prolactin, thyroid, make sure everything's normal, right? You could have some other hormone abnormality you've developed. So that's an easy one. Just get your hormones tested.
Should you take ASA when doing IUI, or is this something that is prescribed?
I believe firmly all fertility patients should take ASA. ASA is hugely helpful in pregnancy. It's good for fertility. It's good for avoiding preeclampsia. It actually reduces preterm labor. It probably improves blood flow. I suspect it increases your chances. So I'm a strong supporter of doing aspirin for every pregnancy. It should be started before you get pregnant. So I just tell patients to go on it and stay on it.
Thoughts on NK cell testing?
Huge believer in NK cell testing. We've seen enormous differences in our practice based on NK cell testing. So I love it. Yeah, we're all about the NKs.
Doctor gave me Clomid, 150 milligrams, no follicles growing on ultrasound, but LH is high. Doctor is suggesting for me IUI.
Huh? That makes no sense. If you have no follicles growing and your LH is high on 150 of Clomid, you're either not responding because you're Clomid resistant or you're menopausal. But those are the only two circumstances in which that's going to happen. So figure out which one it is. And either way, don't do an IUI. That makes no sense if there's no follicles there.
What's up, docs? That's it. They just want to know what's up.
Yibbity, but that's all.
That's it. Absolutely. Hold on here. They did. Oh, I just answered that question. Okay, no problem. There's people saying they're waiting to get their question answered. I answered it now.
Okay.
And the comment section is, are they ever going to answer this question? Is this question ever going to get answered? Yes, we're working down the list, guys. We're getting to all the questions.
Yeah,
we're getting to all the questions.
We're gonna try.
Yeah, big effort.
Yeah,
big effort. Thoughts on metformin?
If you have insulin resistance, it's great. It's harsh on your tummy, so it's hard to take. I always recommend to patients that they go in a scaled fashion. It's great at reducing ovarian hyperstimulation syndrome, although that's pretty rare these days. So yeah, I mean, overall, it's a good solid drug. It works really well. Just has horrible side effects. 70% of patients will quit metformin in the first 3 months because of the side effects.
Oh wow,
it's rough.
That's rough.
Yeah, it's horrible.
70%.
70.
Big number.
Yeah.
Hi, Dr. V and T. What's the optimal E2 level before transfer with endo?
So there is no optimal E2 level, period. Certainly not with endo. But there is one study that said you should have a minimum of 100 picomoles per liter before you do a transfer. So some people try and stick to that, but everybody's got 100 picomoles per liter. So I don't follow the estrogen level for your transfer unless it's high, in which case we shy away. But a low level doesn't matter, in my opinion. It doesn't make any difference. There's only that one study that said it was important to have a minimum of 100. And it wasn't like below 100, it was 0. It was just less.
Does an HCG doubling time of 38 hours mean a higher live birth rate generally?
Yes. If you look at studies that evaluate the HCG prediction value, if it is doubling every 48 hours, not 38, you're doing well. If it's every 38, you're doing even better. So as long as it's not going up too rapidly, it would suggest things are going in the right direction. But it's not 100% predictive of success. You can still have miscarriages, ectopics, things like that with a normally rising beta. So don't assume that you're good just because your beta is rising normally.
When we're transitioning between your camera and my camera, you just look absolutely incredible.
I love you too.
All right, I'll take that. Can adenomyosis be introduced due to a DNC? Is adenomyosis more difficult to treat than endometriosis? And will laparoscopy be a good option for treating it?
There are a lot of women that complain about developing adeno after a DNC. I don't know that there's any evidence that the DNC can cause it. And physiologically, it doesn't make sense because your endometrium, which is what's invading into the wall of the uterus, is suppressed when you're pregnant. It's replaced with decidual tissue. So It doesn't make sense that that would be the case, but there are women that complain about it after they've had a pregnancy loss. From the standpoint of treatment, it's the same treatment as endo: suppression, natural supplements, high dose progesterone, immune protocol. So there's no difference that way between ADNO and endo. They're the same thing, just in different locations. From the standpoint of laparoscopy is essentially useless for ADNO unless you have something called an adenomyoma, which is when there is a cyst or collection of adenomyosis cells that look kind of like a fibroid, but they're not. They're actually just a collection of adenomyosis cells. So those you can remove, although laparoscopy for that, I'm an expert minimally invasive surgeon. Even I wouldn't try that. It's very difficult to properly create margins for it. And it's even harder to sew the tissue back together. I've seen it done laparoscopically. I was not impressed, and I would never trust that uterus to get pregnant.
Hi, docs. I'm about to start IUI cycle, and my doctor suggested Clomid and a trigger shot. I'm 44, AMH 1.56, 17 AFC. Husband's sperm analysis was good, 98 mil. Any thoughts on this protocol?
I need to know if you're referring to your AMH in nanograms per mil or picomoles per liter. At 44, with a Clomid protocol for an IUI, even with good sperm, you're probably talking about roughly a 5% chance or less per month per try. And you would be looking at somewhere in the neighborhood of a 60% chance of miscarriage. So if you are intent on doing IUI, it's reasonable. If you want something with a better result, you need to talk to your doctor about alternative options. But we don't push a lot of IUI in patients that are over 40 because the chances of success are remarkably low. So it depends on what your expectations are, what you can manage financially, what you want out of it, what your comfort is with doing, IVF or donor egg or whatever the other alternatives are. So that's like a long discussion with the patient, not something where your doctor can just kind of snap their fingers and say, go do this. You need to know all your options.
A big shout out to you, Dr. V.
Oh, thank you.
For both of my miracle babies.
Aww.
One of them being that cutie holding her embryo photo that I see on the wall behind you.
Oh, that's cool.
Also, a big shout out to Stephanie Lynn Photography for this fabulous shot.
Very nice. Yeah. Well, thank you. Appreciate that.
It's a great photo, by the way. It is a great photo. I actually noticed that the photos changed. I'm like, oh, you know what? That's nice.
That is nice.
Yeah. Dr. V and the start of this caught me off guard. Dr. T and V. Just the complete opposite here.
Wow.
Yeah.
We really turned that one around.
That's why I deserved an extra pause.
I'll take the hit. It's all good.
Yeah. In a previous Q&A, Dr. Victory mentioned that DHEA causes delayed periods. It could indicate that ovaries are getting weaker. Could you please explain how so?
DHEA does not cause delayed periods. If you're on DHEA and your period is getting delayed, I would be worried that your ovary is getting weaker. Now, there's always hormonal changes and swings, and some people will respond differently. But as a general rule, DHEA does not disrupt the balance of your periods normally. It can, but it's not common to see that. But if your period's irregular or becoming more irregular, and you're on DHEA, which you're probably on because your ovaries are weak, you then need to be concerned that your ovaries have become weak to the point where you're becoming menopausal. And I apologize if I wasn't clear about that before.
Stephanie Lynn Photography is also watching today. And she says, thank you.
Hi, Steph. You need to come take more baby photos. Why don't you leave some cards or something so that people know your work and then they can pick them up? She's got her little hashtag thing.
Yeah, she got the QR codes on.
She's got the QR codes.
Yeah, that's right.
Yeah.
Do you include ICSI in your IVF protocol, or is it optional?
Um, we do it automatically for everybody, and it's included in the price of our cycle. You can opt out of it. We don't refund you anything or charge you more or less or anything like that. If you wanted like half or all conventional IVF, you can do that. We wouldn't recommend it, but you can. We have very high success rates with our ICSI, so we recommend everybody do ICSI.
So my question is about adenomyosis.
Okay.
And I'm here in Ireland. And I was told I've got to get meds to go on into full menopause before getting DE. No idea of this is right thing to do. Dr. V.
Yeah, that's the right idea. If you've got bad adenomyosis, you need suppression as part of a adenomyosis protocol. I wouldn't say you only need suppression, but you do need suppression. However, don't do just Lupron. It has to be Lupron plus letrozole. Lupron alone has never been proven to be beneficial. So suppression is helpful for you, but you'll still require other things too: immune protocol, natural supplements, high dose progesterone. There's a bunch of things that are necessary. We have a whole protocol. It's on our YouTube channel, or just consult with us and we'll give it to you.
Your cup has a K on it for Carly.
Is that Carly?
That's what Carly says.
I kind of feel like it looks like an R, which is why I have it, but it's my nurse practitioner Kasha's mug. So, but I like it because it's huge. So I'm sorry, Kasha, if you're watching. I like your mug.
Dr. V is the best, and thank you for being great.
Oh, thank you. That's very sweet.
Fast
We're
forward.
getting a lot of love today. That's kind of nice.
A lot of love.
Lots
of love.
Of love.
Absolutely.
Yeah,
love is good.
That's amazing.
Getting hearts, getting loves. I love it all. How about you talk about low morphology is the question.
Low sperm morphology? Sure. So the World Health Organization says that the bottom 5% of sperm, so like the worst 5% of guys, have 4% of their sperm normal or less. So that's the threshold cutoff. Now, personally, I think that's stupid, but who might argue with the World Health Organization? So
I'll argue with them for you.
Yeah. So the WHO says the bottom 5 percentile of sperm parameters is where they set the threshold for normal, not half, not like, 30 or some other arbitrary number. It's the bottom 5%. So in that category, you have to have 4% of the sperm be normal. So if you are below that, you have abnormal semen parameters. It does not mean that you can't conceive, but it does mean you'll have a harder time. And many of those patients need help. Can bad morphology be corrected? Yes. So vitamin use, avoidance of smoking, drinking, drug use, take frequent ejaculation. Don't take frequent ejaculation, have frequent ejaculation. And as well, make sure that you are avoiding heat, electromagnetic radiation like emitted from your phone, as well as keeping your testicles cold. So we tell our guys to sit on frozen green peas for 20 to 30 minutes a day. It will take about 2 to 3 months for you to have a change in the morphology of your sperm, because morphology has to do with the formation of the sperm. And that's like a 2.5 to 3 month process. So expect that it's not going to change overnight, and don't get disappointed. Hang in there. Sometimes it could take a long time for the sperm to improve. If it's still not improving, despite all the measures I mentioned, you need to see your doc and get ultrasounds and investigations and advanced testing.
How much is genetic testing?
We have different pricing based on what you need. So if you're only doing one embryo, it's way less. If you have 8 or more in one cycle, it's $4,200. So we have like a per embryo pricing up to 3, and then beyond that, we just charge the $4,200. And then if you're doing more than one cycle, we have additional pricing. So it's like $5,000 for 2 cycles, $5,500 for 3 total. And that's the cost of doing it. We're still working out the cost for our own program when it starts in about a month.
So nervous for my 7-week ultrasound tomorrow. Any advice?
Well, I'd love to tell you not to be nervous. Prayer, meditation, yoga, stay calm as much as possible. If you're feeling nausea, breast tenderness, urinating frequently, those are all good signs. And if you haven't had any bleeding or cramping, those are also at least not negative signs. So that's good too. I mean, trust in whatever you believe in and hang in there. In my case, it would be have faith in God, but everybody's different.
Can starting Pred CD6 for a natural transfer cause ovulation or implantation issues? RPL patients.
Ovulation, yes. Implantation, likely no. It would depend on how high your dose was.
Doctor gave me Clomid,
I
150
think we did
milligrams,
that
no
one.
follicle. We did that one, right?
Yeah.
On my second cycle, Clomid IUI, but the nurse is asking me to use OPK, no ultrasound to see if I'm respond.
We used to do that. And there are studies that say that it doesn't make a difference. But then there are other studies that say that it does. We found in our practice, we did better when we monitored the patients, but that's just us. We've presented on the show years ago, like 4 years ago, 4.5 years ago, data that showed that it didn't matter. And then a year or two later, we showed data that showed that it did. So I think the jury's out on that one, but whatever you're more comfortable with.
How do you do a modified natural FET after Lupron? Wait for period to return?
No, we just roll off the letrozole into waiting for their lining to grow. If it doesn't grow enough and we have to start giving more and more estrogen, we stop and wait for the next month.
Going to Instagram. Is there anything that can happen in your life that would indicate that you might have high NK cells?
Oh, wow. Immunoreactivity, asthma, psoriasis, Crohn's disease, thyroid disease, Hashimoto's, Graves, any kind of autoimmune condition, inflammatory joints, that kind of thing. Even people like I'm sure I won't say who, I'm sure someone near and dear to me has an overactive immune system because when they get a mosquito bite, it turns into this like giant pink welt. And I think those people are just overreactive. So they probably do have high NK cells. But could you go through something in life? I mean, I don't think there's anything you could do that would initiate that process, but there's certainly things that could happen to you that would cause that process to occur.
Mr. T. That'd be me.
It's a question just for you. Oh, I'm all
No. The question is very short-lived. Can you ask Dr. V? It's a very short-lived request.
All right.
No, I'm not that special. If you have less of a reaction on your second lit treatment, is that a good indicator that it worked well? Anxious, waiting for retest results.
Yeah, there's no rhyme or reason with the lit. We really don't know what reaction actually means it worked or it didn't work. So I don't know the answer to that.
There's a follow-up that my second lit was less itchy as well.
Yeah. I mean, in theory, if you're responding, it should be. So that would make sense, but we don't have any studies or data on that. There's no itchy post-lit study that indicates the relevance to, whether or not it's reacting.
People are losing their mind at your pricing. My clinic, I paid almost double per cycle.
12,745 monitoring, IVF, ICSI, incubation in a time-lapse incubator, special media if we need it, oocyte activation if you need it, monitoring again for your first embryo transfer and your first embryo transfer, and 1 year of storage. That's all included in that one price.
What else do you want? That's everything. That's the whole table.
It's pretty fair. I mean, I know other places charge a lot more. We just didn't want to gouge people. And I know there's a lot of clinics charging a lot of money, especially some of the Toronto clinics. Wow. When this lovely patient yesterday started crying, I felt so bad. Like, I get it. Business is business. People want to make money, and doctors deserve to be successful too. I'm not going to deny that, but not at the expense of failing to help people. Our goal should be to help people first and foremost. And if you can make an honest dollar doing that, I'm totally kosher with that. I think that's cool. But if you're like gouging people to make millions, I don't know. I don't feel like you're a doctor anymore. You're a moneymaker. Wendy, my wife, was telling me about a plastic surgeon who did Demi Moore recently. So someone online said that she had made an appointment with the guy, and get this, so a facelift. The consult was $1,000 US.
Oh, wow.
Just for the consultation.
Must be good.
How much do you think for the facelift? Take a guess.
30 grand.
120
Wow.
thou. So he then does the Demi Moore thing. She goes and does that movie.
That movie?
What's that movie called?
Oh,
You know the one I'm talking about?
Yeah.
What the hell's that called? Oh, and it was so good too. I loved it. I thought it was amazing. It starts with an S. Anyways,
The Substance.
Substance. There you go. The Substance. So she makes the movie The Substance, where she does look phenomenal. I'm sure she's not watching, but Ms. Moore, if you're watching, you did look sensational. And then this guy now, so the same patient that had scheduled with them for $1,000 and $120,000, she gets a message that says the consult is now $2,500 and the facelift $250,000 US.
Wow.
So think about that. Like, you do like 10 of those a year, you're done. Like, line them up in the first 2 weeks. I'm off for 50 weeks of the year. So yeah, we don't gouge. I'm not Demi Moore's fertility specialist.
No.
That's for sure. And yeah, we just believe in helping people. So all of our prices, we feel, are very fair. And there's lots of stuff we don't even charge for. Like, we don't charge for helping you get your Fertility tests. If you're in Ontario, we don't even charge for managing your Fertility test. We try and help everybody. Even by US standards, our consults for foreign patients are $350 Canadian. Most US consults are like 500 plus. So we really try to just make it reasonable so we can help as many people as possible.
I'm 36. Of course, not me. I just had our first egg retrieval and got 8 eggs, 4 fertilized. However, last minute, we decided not to do PGTA testing. Was I wrong for doing so?
So at 36 with 4 embryos, half of your embryos in theory should be normal. So I can't tell you that you're wrong. The research shows that the time to pregnancy and in a US model, the cost to getting pregnant are better when you've had PGT. And there is likely a reduction in miscarriage rates as well. But are you wrong not to have done it? No, of course not. Like, not in that scenario. If you're like over 38, I really think it's a must. Between 35 and 38, it's recommended by us, but not a must. Below 35, I don't think anyone should do it unless they've had recurrent failures, recurrent miscarriages, or there's a genetic indication to do so.
Hello, Dr. V and cool Mr. T.
Oh, cool Mr. T.
We will be doing Clomid 50 milligrams and trigger prog capsules. Any suggestions? Got pregnant with letrozole, but miscarried early. I'm 30 years old. PCOS.
Well, letrozole has a higher success rate than Clomid does, 27.1% versus, 27.5% versus 19.1% with Clomid over 6 months of use for live birth. It's a study in the New England Journal by Legro, Legro et al. So I'd stick with the letrozole, but aside from that, no, there's nothing wrong with that. I will say we don't use the 50 milligram dose of Clomid. There are too many people that just didn't respond. So we start at 100, but you know, if you're on 50, it's fine. There's nothing wrong with trying that.
Hello, Dr. V and T. I know you have very high success rates fertilizing embryos with IVF.
Yeah.
But does that mean a high live birth rate?
Yeah. Yeah, it does. So our miscarriage rate is generally very, very low. I think it's a combination of the fact that we have a phenomenal lab. I argue one of the best in the world. We have a excellent team. We deal a lot with making sure we've dotted every I and crossed every T. So fertility testing, microbiome adjustments, immune therapies, things like that. And we are very cautious and careful when we are following our patients. Supplements, vitamins, thyroid correction. Like we go out of our way to ensure everybody's going to do well. So, yeah, our success rate is translating into higher fertilization, higher blastulation, lower miscarriage rates for sure. There's no question about that.
I've been doing DE in Cyprus and 2 miscarriages. Discovered ADNO and endo and now 47. Is
Okay.
there any real hope of success?
Huge hope, but I doubt you'll get it in a place like Cyprus. I've never heard a single patient come back from Cyprus that was satisfied. But I mean, if you've got a great clinic, good. You need an endo protocol, an endo ADNO protocol. So happy to share that with you. Reach out, watch our YouTube video on it if you want. But you need an endo ADNO protocol, even for donor eggs.
Transfer coming up end of this month.
Okay.
Will be in my 6th transfer, 4th with my sister DE embryo. Adding Lupron and Neupogen this round and had a septum repaired 1.5 months ago. Hoping this is it. 6 losses.
Oh my God. You had 5 previous transfers with a septum in place. You should reach out to me before you do another transfer. I will happily review your case and help you out before you lose another embryo. So reach out. It's not just about septums, and you should be dotting every I and crossing every T with 5 previous donor egg embryos. And I am so sorry you've gone through that. That's absurd. Totally, totally unacceptably, horribly absurd. Yeah, that makes no sense.
Hi, Dr. V.
Hello.
Can an MRI diagnose endo?
Depends on who you ask. If you look at the literature on this, it's got a maximum of about an 83% sensitivity. So can it? Yes, but you're going to miss roughly 1 out of every 6 patients. So I'm not a huge believer in it. I certainly never order it for that. There are clinics that believe in it. Matt Leonardi, a great surgeon in the Hamilton area, he runs a whole clinic dedicated to ultrasound MRI for this. I'm not a big believer, but you know, for the people that are, if it works for you, great. My problem is this. So you do your MRI, you're positive. Okay, now you need surgery. So you needed to go to the OR. You do the MRI and you don't have endo. Well, there's a 1 in 6 chance you're wrong. And if you can't figure out what else is wrong, and you have symptoms or you have unexplained infertility, you still need to go to the OR. So if you're going to the OR pretty much either way, why are we wasting resources putting you through a machine that goes clonk every 10 seconds as it rotates around you and, makes you feel claustrophobic and costs the government $1,000 or $2,000 each time? So it doesn't make sense to me. If someone can explain to me why we're doing it, I'd be happy to do it, but I don't see the rationale behind it.
So you are of the opinion just go in and do the surgery and find out.
People are afraid of the surgery. I get it. But in the hands of a good surgeon, laparoscopy is very safe. I would not be rushing into anything.
But you can't do any. But even when once you detect it, you still have to do the surgery to get rid of it.
Yeah.
Like it's never not surgery. It's always going to be surgery.
Well, I mean, the people who are in favor of this would argue, well, if you find it on MRI, okay, you needed surgery. But if you don't find it on MRI, why are you putting yourself at the risk of a surgery? My argument against that is surgery is very low risk in the hands of an expert.
Mm-hmm.
So why are we, and it's free to the patient. So is the MRI in Ontario. So I get it, like way more invasive than an MRI. I won't doubt that. I won't question that. Way more risky as well, because you can have complications. I agree with that as well. But therapeutic, whereas the MRI isn't. And so that's the problem, right? Like you're going through all this treatment, and then if it shows you're negative, you still don't know if you need surgery or not. So you still need surgery. So that doesn't make sense to me. Like, why are we doing it if you're still going to end up in the same place?
Do it.
Yeah, just go for the surgery.
Go for the surgery.
On the other hand,
good surgeon as well.
And it takes 6 months to a year to get into the OR.
How long for the MRI?
With me.
Doesn't it take longer for the MRI?
Depends on where you are, but it can. Not a year.
Not a year.
6 months, 4 months, 6 months.
Dr. V, what are your thoughts between inositol SAP and Inosia tablets? I have recently started inositol SAP and have found it to be lightly bleeding for 10 days. What are your thoughts on the difference of meds?
I don't think there's any difference. There's inofolic, which comes in a capsule, which is a little bit easier to take, and has a better distribution, supposedly. There's Inosia, which is a great product. I'm not familiar with the NFH product, but I'm sure it's fine too. Inositol SAP. So any of those would be okay. I don't think any one of them is any better than any other. I do know patients prefer the ease of taking inofolic, but we don't support one product over another. It's actually illegal for us to do that. You looked extremely puzzled there for
yeah, because I don't understand the question.
It's like deep thinking.
There's a lot of words here that might be the first time we say them on the show.
Oh, okay.
And that always works me out. Medical terminology.
All right, I'll fill in the blanks.
Dr. T is, weak in this field. Get me in front of an egg. I know what to do. Put me behind the questions I can answer most. Throw me some vocab. It's just not happening. Anyway, as the question goes. Hi, Dr. V.
Hello.
I was diagnosed with monoclonal gammopathy. Monoclonal gammopathy. Monoclonal gammopathy. That's what you said, man.
Okay, yeah. Monoclonal gammopathy.
Yeah. Undetermined significance. Would you recommend using tacrolimus and prednisone for FET?
Yeah. Plus probably intralipids. I'd probably talk to an immunologist. That's a little more complicated than the garden variety stuff we deal with, but yes. Monoclonal gammopathy.
Monoclonal gammopathy. Absolutely. New word of the day. That was just my kids learning new words.
We need to just get some sort of t-shirt printer and every next show.
Anytime there's a new word, eh?
Say monoclonal. I'm monoclonal gammopathy. Yeah.
See, it's not that easy. It's not that I saw you struggle. Don't make it just a Dr. T thing. Even Dr. V's getting stumped.
That's funny.
Can you please explain how one might know that they have NK cells without blood work? Maybe that's not possible. Just wondering if there may be a precursor to indicate you have them.
I wonder if that was the same person that asked a similar question. No, there's no way to know ahead of time. There are people that have overly reactive immune systems, as I said earlier, reaction to a bug bite, bad asthma, a bad allergies, that kind of thing. But you still don't know if you have high NK cells.
Why is the endo protocol so nasty? Hot flashes are so miserable, but also is a crazy amount of bloating normal?
If you've got a crazy amount of bloating, you may be getting it from the supplements, in particular the NAC. So give us a call and we'll talk you through it. It is nasty because I'm turning off your estrogen, like off. So yeah, it's not I've never ever hidden from the fact that it is not a nice thing to do to a lady, but it works. Globally, it works. Like we get messages every day from people around the world saying, "Thank you, I'm finally pregnant because I used your protocols." So,
hi, doctors.
Hello.
What are your thoughts on dexamethasone as a primer to reduce inflammation?
I will likely switch us over to Dex in the coming months, because the more I'm reading about it, the more I'm getting convinced it's the way to go. We are not there yet, but I suspect I will be soon. So I'm all for it. Good choice.
Here's a question that I'm sure you'll enjoy.
Okay. Is it an error test question?
No. A little bit different, but it'll get the same
reaction.
Same reaction.
Oh, good. All right.
When should you stop drinking before an IVF?
Oh, well, you should never drink. So that's an easy one. Alcohol is horrible for your heart. It's horrible for your liver. It's atrocious for your reproductive system. So as a male, minimum 3 months in advance, preferably longer. As a woman, the sooner the better. Like, just get off of it. Alcohol is a class 1 carcinogen. For people that don't know that, alcohol is known to cause 11 different types of cancer, known to cause heart problems, known to cause liver disease, throat disease, pancreatic disease, on and on and on. The whole pandemic, we all used hand sanitizer to prevent ourselves from getting COVID and whatever else. Hand sanitizer is mainly alcohol. We used it to kill stuff, people. If you're drinking that, you are killing yourself from the inside out. That's what alcohol does to you. It kills you.
Was that right? You like that one?
I did like that one.
Yeah.
Because I hate alcohol.
I know. I know.
Yeah.
Can IUI work with poor sperm motility?
Yeah. In fact, it's probably very well tailored to that, because the process of prepping the sperm will improve the sperm motility. So yeah, it can work. Now, if you've got horrible sperm motility, 5%, 10%, you're probably not going to be successful. But if it's all you can do, it's worth a try.
Hello. I did a medicated FET cycle.
Okay.
Beta was 582, but progesterone was 11. Is that too low? Currently using 800 milligram suppositories.
Nanograms per mil or nanograms? Sorry. Yeah. Nanograms per mil or nanomoles per liter. If it's 11 nanomoles per liter, it's way too low. If it's nanograms per mil, it's borderline low. So I would just bump either with some oral, or I would switch to add in some PIO shot, preferably PIO shot.
From TikTok.
Yeah.
Our friends on TikTok. Oh, it scrolled us all to the bottom. Should we go from the bottom up? Risky. Do you see a lot of patients who have had transplants? 2 of my kids had kidney transplants. Do you see any families needing help due to a spouse being on meds?
Oh, yeah, all the time. We've had lots of those. That's not an issue for us at all.
Why is my TSH high, 3.67, and my beta is 292, 14 DP, 5 DT?
Probably because you're on estrogen. So if you're on estrogen, you should be taking more Synthroid, because it'll jack up your estrogen, but your TSH. But get a full thyroid panel and talk to your doctor.
What's up, docs? Should a transfer be canceled if there are small follicles growing with Lupron?
No, not at all.
Not at all. Is
Triptorelin.
Very good eyes, Dr. Victor. Injections good before IVF after having a lap to remove adenomyosis?
No, you should never do that. Not before stim. If you're doing it before retrieval, no. If you're doing it before transfer, yes, in conjunction with letrozole, but not if it's for stim. You'll suppress and then you won't respond as well.
You know, it's very hard to read the questions on TikTok.
Why?
I got used to it being on the laptop.
Yeah.
And now I'm squinting, man. I'm squinting.
T needs glasses.
No. I'm just saying.
Dun, dun, dun.
I'm just saying. Because it's look. White font.
Yeah.
On handsome Dr. V. I don't know. I can't focus my eyes.
You need me probably to be in black.
That would make it easier for sure. That would make it easier for it's all a blur right now.
I did see you kind of
I'm doing adjustments. I'm doing just to make sure, because it goes over your cup. Like it's going on anything.
Yeah,
right?
yeah, yeah.
So the challenge,
Yeah.
of course, is
We're gonna need a little black banner
right there.
down
That's
here.
it. Then the
Yeah.
questions will be clear. All right. Hi, doctors. Almost 1 year post an open myomectomy by Dr. V.
Okay.
How long should we wait for another referral by TTC?
I wouldn't wait anymore. If you're not pregnant within a year after your myomectomy, that's more than enough time. You should be getting back in and getting treatment.
Male infertility, successful first FET, number 2 ended in chemical, nervous about number 3. Advice.
Don't be nervous. I mean, it takes more than one try sometimes, and miscarriage is very common, unfortunately. So just come on in and try again. I wouldn't be hesitating on that at all.
8:59.
Oh, wow. That just like
That flew.
that flew.
Does your clinic do in vitro maturation?
Yes. In fact, we're about to start something hopefully groundbreaking. So we'll be trying that very soon with in vitro maturation. But yes, we do.
Couple questions relating to blastises. So I'm just going to try and go to the conclusion. How to make it better? Improve blastocyst rate or egg quality.
Better eggs. So lower weight if your weight is high, lots of vitamins, acupuncture, yoga. The more I read, the more I'm becoming a believer in something called NAD plus, nicotinamide ADNO dinucleotide or something like that. That looks really good. There are lots of supplements you can take for sure. There may be some benefits to other medications like rapamycin. We don't know yet. So all of those things can help. Sperm quality, no smoking, no drinking, no drug use, exercise, frequent ejaculation, cold therapy. All of those are important. Make sure that you are optimizing frequency. And then as far as the rest of it is concerned, honestly, it has a lot to do with your lab. So good lab is going to pick good sperm, do a good egg prep, get high rates of fertilization, put them in a time-lapse incubator so they don't keep getting pulled in and out, and then sit there and watch them grow. And use the right media, oocyte activation. We're pretty much activating everybody's eggs these days. So
Couple of questions in this one question here. So bear with me here. Let me get through them all. One questionnaire, 700,000 questions.
okay, got it.
Okay.
Fire. Put it on you.
Put it on me. One
No, no.
second. I'll put it on me.
Oh.
Don't worry. Just say something great.
Okay. Did we lose the battery finally?
No, it's fully charged.
Are we going to lose TikTok now? Just touch it and it'll remember that we're there.
Yeah,
Yeah.
we're still there.
Okay, fire.
All right.
On you.
Taking shots. Here we go. Whoa. Yes, Dr. Victory.
Yeah.
How much are your consults? This is number 1.
Okay.
I live in MA.
Can I do it one at a time? Because otherwise I'll lose track.
Okay, let's go with that.
$350 Canadian.
I live in MA and have recurrent miscarriage at 6 weeks, and my doctor now only wants to do IVF, but we can't do it due to religious reasons. All my labs are normal except DHEA was 300. Hubby samples were good too. I heard that it takes 3 months for eggs to be exceptional and prep your body for 3 months to have successful pregnancies. Is this true? Not done yet, but you can go for that. Go
So
for that
no,
part.
that's not true. Sperm takes 3 months. Eggs, we don't know because there's no way to test for that. You don't necessarily need to do IVF, although it would definitely improve your chances of success and give you better control. There are religiously sensitive ways to do IVF, so that should be kept in mind as well. We have many patients with objections where we've made it where we just make one egg at a time, one embryo at a time. So we've got all sorts of natural ways to help you with IVF as well. And then the final part of this is that there is advanced testing you should do from someone that's an expert in order to figure out why you're having recurrent miscarriages. I couldn't say this enough. IVF is not treatment for recurrent pregnancy loss. It's not treatment at all. IVF will not get around whatever is causing you to have miscarriages. You're going to have perfectly beautiful, happy, healthy embryos that are still going to miscarry if you don't know what the problem is. So you need to be with an expert that is capable of figuring out what's wrong. Then you can decide, do I want natural? Do I want IUI? Do I want IVF? What are my options? What are my goals? What are my, financial and social and moral and whatever acceptance is? But you don't know what's wrong yet. If you don't know what's wrong, IVF isn't going to fix it. That's a money grab. I would never do that to you. First, I'll figure out what's wrong. Then we talk about how to fix it. Next part of her question.
Next part of her question about I want to take a little break and go to TikTok.
I'll just finish her question. She's in the middle. Come on.
Oh, that's so crazy.
It did it again. Oh, careful. Tark almost tripped.
I don't know why. Yeah, we were here and then this one.
Did it stop?
Yeah, it stopped.
Oh, it stopped. Ouch.
Full stop.
Our TikTokers.
Sorry, TikTokers. As I'm reviewing the questions. All right, you're back on TikTok.
All right. How did we do? Lots of people?
Yeah, you still have people.
Okay.
You still have people. I don't know how that happened. Gotta figure that out next time. Oh wow. Oh, that happened.
Okay, go back to her question.
Yeah, of course. Now we really got to go back. But what I wanted to say, there was an individual, Masha was her name on TikTok, and she said we didn't answer her question, but I don't think her question went into TikTok.
Oh,
Like
okay.
sometimes when they type something, sometimes it doesn't show. It doesn't show.
Okay.
So Masha, your question, I do not see it.
Okay.
Yes, I remember the question now. I wish I could do fertility.
Okay.
I can't afford it in the US. My doctor says for me to do the Emma and Alice. It's like $1,500 or so. I wish that you were an MA. There's no one here, and that's knowledgeable and understanding. God bless you.
Well, God bless you too. Thank you. And you don't have to have me there. We can do it online, and don't do Emma and Alice. Emma and Alice, the company believes that 20% of women have a sterile uterus. That's biologically impossible. So you're wasting your $200. And fertility is not much more than that. And you'll get immune and microbiome if you use our code. So talk to me first, and then we can go from there. From one very religious guy to you.
906.
I think we need to call it a show.
Call it a show.
Thank you all for joining us. That was a fun show. I like that one. It was,
that was a good one. Yeah.
We wish you all a very wonderful night, a great week. We have this show and then next week's show, and then I'm gone, I think, right? Yeah. Is that right?
You have your show next week with the podcast.
21.
And then
right?
you have one more after that. One more show. That's 22.
21.
Or 20 something. And then there's a 30. Hold on, I got my calendar right here. There's 22 and 29.
22.
Yes, 22 and 29. And then you're gone.
That's my birthday.
29, I know.
Yeah.
I have it in the calendar.
Are we doing it on my birthday?
You shouldn't. You shouldn't.
Why don't you guys let us know in the comments if you want us to do it on our birthday. Also, a post will come out very shortly about whether or not a doctor should be forced to do a procedure they don't necessarily support or believe in. I am very hopeful you will all jump on and comment on that post. I would really be happy if that went viral, because I had literally dozens of women telling me I should be put out of business, lose my license, and that I love this part, I'm a misogynist, because I said that I don't believe in tying the tubes of women who are less than 35 years of age, mainly because I see them all sitting in my exam rooms right here with tears streaming down their face because they didn't understand what they were doing when they did it when they were young, and now they want a different approach, and they are stuck either having a tubal reversal or IVF, and they can't afford it. So I want to know if a doctor should be forced to do a procedure he or she does not believe in. He, she, or they.
Take your birthday off, Dr. Victory. Have a nice dinner.
Yeah. I think the wife is going to execute me. Maybe we can do it on the Monday.
Yeah. Sure.
You want to do that?
I'm here.
Yeah.
Yeah, I'm available.
And I wouldn't be surprised if we celebrated on the weekend anyway. So we'll see.
I see.
Yeah.
All right. Let us know.
Yeah.
We'll be here.
Yeah.
We'll be waiting.
The week after, I am on holidays. We're chasing my wife's favorite opera singer.
Questionable relationship at best, Dr. V. You should ask the fans.
In his defense, he is a wonderful human being. He's extremely funny, and we're having dinner with him. We're friends. So, but he's a world famous opera singer. So, JT, I look forward to seeing you soon and your wonderful family. And Wendy, I love you, honey. Don't get me in trouble. And we'll see you next week on Fertility Fact or Fiction. Have a great night.